Well, thanks everyone for having me tonight and sharing part of your evening. I've been invited tonight to discuss a test called a BCI test, a breast cancer index test, and its role in extended endocrine therapy decision-making for hormone receptor positive early stage breast cancer. My name is VK Gadi. I'm a physician scientist here at the University of Illinois Cancer Center in Chicago, Illinois. I'm a 10-year or thereabouts user of this test, and I'm happy to share my personal experience as well as we go through the slides. So again, we're going to focus on this landscape of decision-making around this extended endocrine therapy juncture for patients with hormone-positive breast cancer. I think this is not news to anybody, but it was very striking to see it being presented and printed over the last several years, which is for women who have taken endocrine therapy for 5 years, they do well. They receive clear benefits from having done so. And this is an early stage positive breast cancer. Clinically, people we think are going to do well. But sadly, one of the striking things that seems to happen is that even though there's this initial benefit here and that benefit is maintained, unfortunately, the curves keep going up. And so even with tamoxifen in low risk disease, there are patients who continue to experience recurrences. And it's for this reason that we're here tonight to discuss if a little is good, could more be better? So this has been tested over and over in a variety of different settings, context, trials. And this is just a snapshot of 6 trials that includes almost 25,000 women. And what you'll see is there are trials where patients may have started life on tamoxifen and then ended up on an AI. They did the TAM to TAM strategy. The AI followed by an AI strategy was also attempted. A variety of different context settings, durations of exposures, really big size trials in some cases. And the upshot of all of this is that there's a very consistent 3 to 4 or 5% benefit that's observed in all of these trials. And so just put another way, that means if 1 out of 20 are benefiting, 19 out of 20 are not. And the question then becomes, is there a way we can enrich? Can we make this number bigger so that we're targeting patients that are more likely to benefit from making this decision about extended endocrine therapy? So here we go again. So 5% benefit. And then another way to put that is the number needed to treat is 1 in 20. On the far right, the number needed to annoy is 1 in 2. So these are tolerability issues associated with extension of endocrine therapy or any endocrine therapy for that matter. Hot flashes, sexual dysfunction, arthralgia, myalgias, all of those we think of as kind of menopause type changes. And then of course, some women will even report and have documented mild to moderate cognitive impairment. But it's in the middle. These are the adverse events. And here you're seeing a number needed to harm of 1 in 10. With the SERMs, we see things like embolic disease as well as endometrial cancer. And then with the AIs, the estrogen deprivation strategies, we see bone toxicity and even some signal of heart disease in this extended setting. So even though there's some real benefit here, there's a real price to pay. And you, of course, really don't want to see a number needed to harm that almost exceeds the number needed to benefit. And so we have a tool here today that is capable of doing 2 things. It's 2 tests in 1. That's the BCI test. On the right, you're seeing a prognostic signature. And this is the gene expression, the mRNA analysis of 11 genes. There's a special algorithm that looks at these genes. And based on some studies we'll look briefly at tonight, are benchmarked towards prognosis in that 5th year and beyond. And I would argue when you look at the data compared to a lot of other tests, this is probably the most precise prognostic tool we have for that extended endocrine therapy, just in the way it's been benchmarked. But on the left, you have the predictive assay. And this is really just 2 genes, HOXB13, IL-17BR, 2 genes we've known about for some time, but a separate algorithm that looks at them creates a ratio. And it turns out as that ratio keeps going up, it's more and more associated with an endocrine sensitivity of the cancer and therefore predictive of benefit from extended endocrine therapy. The HOXB13 is a discovery factor for a pioneer factor for the estrogen receptor that helps it land in the appropriate places on the chromatin, activating the gene programs that estrogen is thought to activate. IL-17BR may reflect the inflammatory microenvironment of a dormant cancer cell. So it's just the ratio that really helps us determine the endocrine sensitivity of the cancer. This test has been around for a while, and as the data is accrued and become more robust, It's finally risen to the point where using a dispassionate review system of data and just making a judgment on the quality of that data, we now have two major guidelines. I would argue not just guidelines for the United States, but really for the entire world, that have elevated this particular assay into sort of the recommended decision-making spaces. So in the NCCN in January of 2021, ASCO in 2022. So here first is the ASCO guidelines, and I'll just walk you through them just a little bit because they slightly differ from the NCCN guidelines. The BCI, they specifically say, can be offered up to 3 nodes in patients who have completed 5 years or thereabouts of endocrine therapy and who at the time of the ordering of the test have not recurred, making them eligible for extension of endocrine therapy. And the test can speak to whether or not tamoxifen AI or tamoxifen AI was used and can be followed with any form of endocrine therapy. And they go on to point out that the other tests that we might commonly use, for, especially in those first 5 years, are identified as having insufficient evidence to be predictive of benefit in this extended endocrine therapy. When you look at the NCCN guidelines, they actually do a nice job of listing the different assays that we might use in breast cancer. And you can see on the far right the level of evidence. And fortunately, all of these really have a high quality of evidence, 2A or greater. Level 1, if you just remember, is really a designation reserved for prospective randomized controlled trials that test the test. And so you're looking at the Oncotype test, the 21 gene recurrence assay in both hormone positive, node negative, and node up to 3 nodes positive. Didn't really pan out for the premenopausal group, but clearly in the postmenopausal was able to predict who did not benefit from chemotherapy. And then similarly in the node negative group, there was essentially at the end of the day a dichotomous score for that group as well. In the mammoprint test, both up to node negative and up to 3 nodes are included. There was a smaller subset that was randomized for determining chemotherapy, but after some back and forth, this was a randomized control prospective trial. And while it is strictly speaking the way it was set up, just a prognostic assay, it can be used regarding chemotherapy decision making, and also now has level 1 evidence. When you look at all the other tests, though, they are prognostic and do a reasonably good job, especially in the first 5 years of whether or not a cancer might recur. But the way that BCI was developed and benchmarked in this extended adjuvant setting, it's both prognostic and predictive of benefit in that setting. And because of the nature of the studies, the robustness of the studies, this level 2A evidence is not just based on 1 or 2 trials, but several. And because of that repeatability of the finding, it's been elevated to a 2A. So just to keep in mind, these are prospective trials that are testing drug therapies. And this is a retrospective look, looking at those blocks to see how this test performs. That's the distinction here. So the NCCN guidelines speak to different aspects of this data. So they specifically call out a number of trials, MA17, Transatom, Ideal, at the last guideline update, and there's actually more data coming out. And they look at hormone receptor positive disease up to T3 tumors, node positive, and show that patients who have a high score on this H/I index are the same that are associated with significant improvements in disease-free survival compared to the control arm. Moreover, they talk about how BCI H/I low patients derive no benefit from extension of endocrine therapy. So slight difference in language. So how do we arrive at those guidelines? And that's really needs us to take a look at the actual data. So from a bird's eye view, these are 5 trials that can inform us with regards to how this biomarker speaks to the endocrine sensitivity of the cancer. And you can see just from the way the studies were designed, a variety of different studies, a variety of number of patients, but there's a very consistent finding of roughly 2/3 relative risk reduction in all these studies for patients who have an H/I high score. And when you look over the patients with the low score, there's a very consistent absence of benefit for that patient group for extension of endocrine therapy in all these trials. So really, when you're doing a biomarker development, what you want to see is that it performs almost in a real world setting. When you look at all these different trials and how patients were receiving therapies, that it behaves and performs the same across those. So this is not an experiment that was just done once and then we're like, oh, it works. They just kind of kept going back and building on that evidence. And that's compared to some of the other assays, this is really nice to see. So now we're going to do a deep dive into a handful of these trials. I will just say we're going to start with MA17 and kind of move forward. Don't talk a lot about the Stockholm trial because it's not a population reflective of the types of patients we take care of now. That trial had tamoxifen versus, I'll go back a slide actually, had tamoxifen versus no therapy in the first 5 years of treatment. We've answered that question. We haven't gone back and re-challenged that question. And so it's really not benchmark for predicting decision-making in that early phase. It's really the evidence that we're going to look at is in that extended endocrine therapy. So here's the first of these, MA17. Patients were generally on tamoxifen for 5 years, at which point they were invited to be randomized after a roughly 0 to 3 month washout period. And here are the randomizations to AI versus placebo. So in the validation study, even though this is a much larger, almost 5,000 patient study, they were able to capture blocks from about 249 patients. And in the parent study, there was a difference of about 4.6% between the AI and the placebo arms. And in the sub-study, you're seeing the same 4.6% difference. However, when you subset the patients based on an H/I low score versus an H/I high score, you see that there's no benefit here in this group. And really, the entire benefit found here is hiding over here in the H/I high score, p-value of 0.07 for this. So overall, this is a 65% relative risk reduction. And the p-value for this entire finding is 0.03. And similarly, even though it looks like there's a small reduction here, the confidence intervals for the low group widely cross 1. So this is a small study, the single study, first study that really just sort of set the expectation that this could be a test that speaks to endocrine sensitivity and therefore benefit in the extended adjuvant setting. So in order to build on that data, a couple more studies were looked at. And the first of these I'll share with you is the TransATOM trial. So if you guys remember, ATOM was another big study with several thousand patients, and patients were previously on tamoxifen for 5 years. And here the randomization was to discontinue therapy versus continue 5 additional years of tamoxifen. And I'm showing you for the time being the node positive data. When they looked at the node negative data of the parent study, there were so few recurrence events in the node negative patients that a biomarker could not be applied to that patient to meaningfully identify benefits in any group. So it's really not a failure of the biomarker, it's just that there just wasn't that many events in the node negative group in that particular study. However, in the node positive patients, you see a non-significant difference between the two arms of roughly 4.3% favoring the tamoxifen. However, and this really did evoke what was observed in the entire population as well. But when you look at the H/I low scoring patients, no benefit in this group. However, the entire benefits seen in this node positive group was over here in the H/I high score, the yes group. And so here again, when they computed an odds ratio, the hazard ratio was 0.33, 67% relative risk reduction, crossing the 1.0 mark for the low group, therefore not significant, no benefit over here. And for this entire population, you're seeing an ability that this could discriminate between those who benefit and don't with a significant p-value. Okay, now we're getting a little bit closer to what a contemporary population in the United States might look like. So this is the IDEAL trial. This is actually a European study. And this parent study had about 1,900 plus patients. And in distinction to the previous two trials, this was really a high-risk patient group. A lot of these patients required and did get chemotherapy in the early adjuvant setting and had other high-risk features like node positivity, et cetera. And patients entering the study could have been on tamoxifen, could have been on an AI, or could have even entertained the switch strategy for 5 years, at which point they were randomized. And here the randomization is interesting. It's 2.5 years of an AI versus 5 years of an AI. Note that there is no 0 years of an AI. The investigators, as they were designing the study, felt that this was a higher risk group, that withholding any extension of endocrine therapy didn't maintain equipoise in their view. So they really randomized to just 2.5 versus 5 years. So total duration of 7.5 versus 10 years is what we're talking about. For the entire study, there was really no statistical significance for the entire study. When they looked at this, and the difference was really modest, it was only about 2% or so. But for this subset, it's almost a 5% difference. However, still not meeting any statistical significance. So still a small favoring of the full 10-year of extension compared to the 7.5 years. But when you did really look at those with a low score on the HRI index, there's no benefit observed. And really all the benefits that were able to be discerned were in the HRI high group, a nearly 10% difference between the 10-year arm versus the 7.5-year arm. Put another way, this is a hazard ratio of 0.42 or 58% relative risk reduction, again, evoking that roughly 2/3 risk reduction for the HRI high group. And the low group, of course, again, did not have any benefit associated with it. This study also allowed or permitted folks to just analyze any patient exposed to any AI. So compared to the prior slide, we lost about 100 plus patients, and here we're just focusing on the patients who'd seen any AI, again, 7.5 versus 10 years of therapy. And here, for the all patients group, there was a nearly 6% difference for the folks who extended for the full 10 years. However, when you did subset the patients on the HRI low versus the HRI high group, no benefit here, all the benefit over here in this group, really a doubling of what we saw in the entire population there. And here again, a hazard ratio of 0.34 corresponding to a 2/3 relative risk reduction, and no benefit here in the HRI low group. So very similar to the validation study within IDEAL for all patients. We're seeing really not a lot of difference with those patients who had AI in the first 5 years of any duration. And the last validation study I'll share with you for extended endocrine therapy predictive benefit is NSABP B-42. So compared to all the other trials, this is an American trial. This really evokes the contemporary North American population that we might see. You can see it's a big trial, almost 3,900 patients. Patients in the first 5 years could have been on an AI alone, or could have been on a switch strategy with tamoxifen followed by an AI. Here again, they were randomized to AI versus placebo for 5 additional years. For the parent study, the entire study that was powered for disease-free survival, there was a 3.3% absolute difference between the arms. But many of the events were local, regional, and new breast event recurrent disease-free survival endpoints. And so as a result, they actually did look at distant recurrence carefully. And there was a 1.8%, so a modest difference, 1 in 50 patients. But here, a hazard ratio that was significant, a p-value that was significant, leading some people to say, oh, okay, this is a positive trial, and it really establishes that we should consider extended endocrine therapy in a contemporary North American population. However, when we applied the BCI test to the study, it will show a signal, but there's a few caveats to that. There was some statistical work that needed to be done. First off, the translational study did not meet the primary relapse-free interval endpoint for B-42. And part of that is post-hoc, there were so few events for this relapse-free interval, which includes local regional relapses and metastatic recurrences, but does not include death or other cancer events. So it's an endpoint that's much more relevant, I would argue, for medical oncologists. And in this post-hoc analysis, you'll see compared to IDEAL, that was a European study that had higher risk patients, they were 88% powered to show a difference there. Unfortunately, post-hoc, only 50% in the B-42 study. So again, a lot of the events were really driven by contralateral new breast primary prevention. The other thing that you see in B-42, which again you see in some of these other trials, notably ATOM, for example, is that as cancer cells are lifted from the suppression of endocrine therapy, it's not like they all wake up all of a sudden and start dividing and growing. And in fact, there's some proportion of patients whose cancers remain in dormancy for quite a while. And you can see in the study, for almost 4 years, there's no difference between the arms for patients who are in placebo versus letrozole. But then you see this difference starting to emerge. And when you really start looking at the data 10, 12, 15 years out, there's a durable difference between the two arms. So when you're doing the translational endpoints like the BCI test in a trial like this, you have to account for that time-dependent recurrence. And so you can do a time-dependent analysis for that. And so that's illustrated here on the two graphs on the right. So first on the BCI H/I high index, once you start counting at year 4 and greater, you actually start to see a signal emerge and almost an 88%, an 80% relative risk reduction in that setting. And then for the low group, again, the curves don't separate at any point during that time continuum, suggesting endocrine sensitivity in those particular tumors. So for putting all that together for B-42, almost 2,200 patients were in the validation study, so a big validation study. And for the entire 2,200 patients here, you're seeing a hazard ratio for the H/I high patients of preventing recurrence of almost 71% relative risk reduction. And here again, even though it looks like it's tilting towards some benefit, the confidence intervals really widely cross 1, suggesting really no benefit in this group. So here we have a study that identifies a group, statistically significant benefit for distant recurrence prevention in the BCI yes H/I high group, and very similar again to what was observed in the other studies. So that's just a high-level overview of how the test performed and could add value for making predictions about extension of endocrine therapy. As I indicated, the test is really 2 tests, and the other aspect of it is the prognostic piece. And here you're looking at 4 different trials. Really, all these patients stopped at 5 years, and we continued to see what would happen in terms of late distant recurrence. They were not exposed to additional endocrine therapy. And what you're seeing is, reasonable sizes, almost 2,000 patients in the data set here. Postmenopausal, some premenopausal, some patients getting TAM, some patients getting TAM or an AI in these trials. So a very different set of circumstances that these patients are going through, suggesting again that this is a robustly validated prognostic tool across a variety of different types of populations of patients. So putting that together and then operationalizing it in a clinical practice. So what does that look like? First off, just starting with the report. Like I said, I've been ordering this test a really long time, and the test, I will just admit, was very challenging to go through, and more so to walk a patient through. They've worked very hard to make this just an easy to understand test. On the top, you have a dichotomous result. Yes, you will benefit. No, you won't benefit. And then on the bottom, you have a continuous percentage identifying what the specific risk for recurrence is for node positive, node negative patients, et cetera, very specific to the patient sitting in front of you. And you can apply those together to sort of understand what the benefit for a specific patient might be. Here's an example of a no report. So this is a patient who not only didn't have an endocrine sensitive tumor, suggesting no benefit from extension of endocrine therapy, but she also had a low risk, 2.2%. So really, this is a report where you can happily look at a patient and go, hey, you've done everything you're not supposed to do. There seems to be no additional value for your tumor for extension of endocrine therapy. So putting this into practice. First off, I think we all do this. We look at the clinical factors of the patient sitting in front of us, and we try to make some estimation of long-term risk. And in fact, the ultimate expression of this is we have calculators that we can plug in numbers and sort of guess. But the problem with this is these estimates can mislead us or miscategorize the patients. And so if you're able to get a molecular sort of assessment of the tumor, you get a different story. So on the left, you have patients who we conventionally would say, oh, N1 disease, this is high risk. You should do extended endocrine therapy. But fully a quarter of the patients in that group really have low benefit because they have limited risk for recurrence and or predictive benefit from the assay. On the right, you have a patient group that we would often look at and go, oh, T1 tumor, no nodes involved, you're good, you don't need to do a whole lot. But here, even though there's this sort of clinically low risk disease, a quarter of the patients at a molecular level have high risk disease and may actually benefit from extension of endocrine therapy. So this cognitive dissonance between what we're saying clinical pathologically and what we're seeing at a molecular level, just can miscategorize patients. So what does this look like from one of the actual studies? This is, again, a couple of scenarios from the IDEAL trial. On the left, you're looking, for example, at patients who have node-positive disease, larger tumors, and have HRI low tumors, and you're seeing really no difference between the 10 and the 7.5 years of extension of full endocrine therapy in this patient group. It's not shown here, but if you look at the entire population, you see a little bit of difference between the two arms. But when you look at the HRI high group from this patient, this N plus T2 or greater tumor, you see almost a 12% difference in that population. So this is discordant, right? You know, these are patients we expect to benefit, yet they don't benefit. On the right, here are low risk patients. So T1, grade 1 tumors, and you have high scores on the BCA HRI test. And this is a pretty fair group from this trial, 220 patients. And here in this otherwise clinically low risk group, but a molecular high risk feature, you're seeing an almost 12% difference between the full 10 years versus the 7.5 years. And again, not shown here is for that entire PT1 grade 1 group from this study, there was a very marginal difference. And when you looked at the low risk patients with low HRI scores, there was no difference between the two arms. So lurking in these high risk and low risk are patients who either don't or do benefit from endocrine therapy based on this molecular signature. And of course, we've always had ER and PR, and we've always been taught, oh, ER and PR, you know, really, if it's the quantitative amount of those things that really tell us if somebody might benefit from endocrine therapy. And yet, when you look at this as a continuous variable of the strength of ER expression as a percent of the positive cells, what you see is really a fixed benefit for patients who do 10 years. So, you know, you get a small reduction across the entire spectrum for 10 years versus 5 years of endocrine therapy. And when you look at the PR, you see a similar phenomena here. So what this suggests is that the level of ER and PR expression is not correlated with the benefits from extension of endocrine therapy. However, when you look at the HRI low versus high, and again, it is a continuous variable that we actually draw a cut point for to say high score, low score. But when you do this, you're seeing that once you start tipping over into the high values, here's the 10-year arm showing the relative risk of recurrence. And you can see as that number increases, the magnitude of the benefit for you being on endocrine therapy increases. So this is what a curve should look like if it's correlated with benefit compared to the ER and PR expression. And it's the only thing, to my knowledge, that's correlated in this way for extended endocrine therapy benefit. I get this question all the time about, oh, you know, I ordered a Oncotype. Why do I need a BCI test? And, you know, in terms of the prognostic value of late distant recurrences, what happens with BCI is that you get a very narrow confidence interval on what that number could look like. And this is just showing you the node negative as well as the node negative HER2 negative population. Really not a lot of difference here. Significant P values and you know, a very clear hazard ratio it's got narrow confidence intervals around it. When you look at the Oncotype score, and again, this is different than from years 0 to 5. We're now at years 5 through 10. You're seeing that the test actually doesn't discriminate. The confidence intervals cross 1.0, and they're not significant for this interaction. So essentially, to illustrate this, if you're following the confidence intervals around your estimates for recurrence, for BCI, they stay tight around that interval, but for Oncotype, they start getting wide. Some of the other tests also do that. They just sort of fall apart from that 5 years onward. So how would we, you know, share this with patients? And as we share it with it, how are they going to react? And kind of how does it affect our practice clinically? First off, you know, and this is a pretty cool little study from Yale and the folks at Pitt, showing that when we order this test, 30% of the time, we're going to be saying something different to a patient than what we anticipated we might say ahead of that. And that's really jives well, right, with the 20-25% we were talking about misclassifying patients. Flipping to the patient side, you know, we know endocrine therapy, especially the longer you're on it, is just harder to be on. And so lots of people discontinue. 40% of the time, just straight up side effects, but a variety of other things are often cited, leading to discontinuation. And yet we know if our doctor saying you should take this medicine, but a patient doesn't, there's a loss of life associated with that non-adherence, almost a 4% difference between those who can adhere versus those who don't. So these are, disturbing things to see. We recommending a drug, patient can't do it, and then there's a price of having being paid by the patients for not doing it. So what if we had a test that at a molecular level was more convincing than just sort of those clinical factors that we typically share? Would patients start off the day saying, oh, I understand my risk better, I'm more likely to do this? And that's exactly what you see. So this is not, I'll caution you, it's not the same as I did do this for 5 years, but it's patients committing to saying, oh, I understand where we are, I'm going to do this. And 82% of the patients recommended for extended endocrine therapy said they would be more likely. Moreover, there's this emerging concept of decisional conflict with our patients. And it turns out, interestingly, a molecular tool like this actually can decrease decisional conflict by helping patients understand at a different level what their risk is for a delayed recurrence. So this is a nice tool, for having those discussions with our patients who are really struggling with this idea of going on for another 5 years with endocrine therapy. So where do we put this into the workflow? Again, it is for patients right now, for patients who've done 5 years of endocrine therapy. They have to have hormone receptor positive disease, of course. It's the most validated for this. It's the only validated test for predicting of endocrine therapy beyond those 5 years at this time. And then as a result of that data, and not just one trial, right? Like 4 trials plus a 5th sort of derivation cohort trial. When you look at all of that, it's hard to ignore. And so when you have our guideline experts who are looking at this and making similar decisions to each other, that's also really reassuring that this is a test that can help in this extended endocrine therapy decision making. This is the fine print. This is essentially the Medicare coverage statement. It just really, if you go look it up, it highlights a lot of the things we talked about: hormone receptor positive, up to 3 nodes, early stage, recurrence free. You can look this up if you like, but it really evokes what the data showed. Who is this right for? Well, there were pre and postmenopausal patients, up to 3 lymph nodes, but certainly node negative, up to T3, any grade of tumor. I didn't show you the data. I showed you a little bit of the data, but HER2 status doesn't matter. If you really look at HER2 positive cancers, they are at risk for late distant recurrences, particularly when they're estrogen receptor positive. There is crosstalk between those two. So this idea that the cancer still could be endocrine sensitive and you can have a biomarker that speaks to that is still very, very relevant. And certainly in the trials, these patients were included. Any ER or PR expression is needed. Chemotherapy decision-making really is not affecting these dormant cancer cells that we're trying to continue to silence with endocrine therapy. So these are really 2 distinct things. Of course, they need to be disease-free. And with thousands of patients studied now in those trials, you are going to certainly have a lot of ductal patients, but 15% or more of the patients will have had lobular histologies, and there was no difference observed in terms of whether or not this test could help or not help in that setting as well. So really, any histology is fine. Closing up now, I'm going to go through 3 actual cases, and they go from tough discussion, easier discussion, slam dunk discussion. So we'll just kind of walk you through why that is. So patient 1, invasive ductal carcinoma, T1C N0. She's postmenopausal, node negative, small tumor, high grade, really strong ER and PR expression, not HER2 positive. And she gets it ordered in that close to 5-year window that is consistent with, if you want to call it, the label on the test. And here's a patient who actually has a high risk of recurrence, almost 10% after 5 years moving on forward. That's clearly a high value. Yet at the same time, she does not have an endocrine sensitive tumor that suggests she would benefit from extending endocrine therapy. So put another way, 0% times 9.7 is still 0%. There's no benefit for this lady to continue endocrine therapy. And so this can be rough to talk to a patient. About 10-15% of patients may fall in this category. And I'll just share personally, went from diagnosis onwards, not only am I pushing this concept of endocrine therapy, but I'm also pushing a lot of lifestyle changes that do things like lower insulin resistance and increase in higher quality calories, exercise. So all those lifestyle modifications that we also know are statistically associated with recurrence benefits, we've been doing all of that. And so I really try to sort of highlight that, this is a teachable moment. You've been doing all these things. Gosh, aren't we glad we've been doing that? Because that's actually more important in your particular cancer than an allopathic intervention like a tablet. Case 2, a little bit different. So 55, node negative, small tumor, grade 2. Here, again, good PR and ER expression. Again, ordered consistent with sort of the recommendations of 5 years after diagnosis. And here we have a lady with a relatively low risk, 5% recurrence, yet she has an endocrine sensitive tumor. And so when you take this sort of 5% and multiply it times the 2/3 relative risk reduction, you have a sort of a 1 in 30 patient benefit here, right? 3%, 2% benefit. So this is, it's there. There's a statistical benefit to a patient like this, but the value of the extension is not better than where we started, which is 1 in 20 patients benefiting, right? And so here's a patient you can have a discussion. And if she really wants to keep going, there's no, there's potentially something to be captured here. But this is a patient that also could just simply stop because her risk is actually really low for recurrence. Here's case 3, invasive ductal, again, T1C, N1 this time. 54, 2 nodes, grade 2. Interestingly, discordant ER and PR expression, HER2 negative, and again, ordered within the sort of the 5-year ballpark of this. Maybe this is a lady that did chemotherapy, for example. And what we see here is a lady who has still a persistently high risk, almost 11%, and a tumor that still apparently had endocrine sensitivity to it. So this is a yes. So yes and a high. And here, if you were to sort of just back of the envelope, do the relative risk reduction, if you 2/3 off of that number is nearly an 8% difference, right? And so now we're looking at a patient group that 1 in 10, 1 in 12 patients is going to benefit from this extension of endocrine therapy. A lot more value to that extension for this type of patient, and perhaps somebody that's more easily convinced that this could be helpful for her. So that's the last slide, just operationalizing it. I see a few questions here, so I'm going to stop sharing and then maybe we can tackle some of these questions here. So the first question is BCI used for both premenopausal and postmenopausal women? So I'll unpack that a little bit. The answer is yes. A lot of those specifically older trials had plenty of premenopausal women who enrolled, they may have been postmenopausal at the time of enrollment into the extension arm, but they were premenopausal when they started their breast cancer journey. And so they are captured in those data sets. The remaining question, of course, is that we now have SOFT and TEXT and these other trials showing that we can combine ovarian suppression with endocrine therapy for very high risk or very young women and see a pretty significant gain for those patients in terms of intensifying their endocrine therapy. What we don't really have yet from those women is sort of these long-term biomarkers. And we don't also know if the test predicts even for that intensification of therapy in those first 5 years. What I can just tell you is that I think that's a topic that's going to be discussed in a meaningful way at San Antonio. So we'll have some data really soon about that. The next question is really has to do with this ovarian suppression and AI. And then another question here, in postmenopausal women with high BCI, giving extended AI for a total 10 years, would you give adjuvant bisphosphonates, for example, Zometa? If so, what is your recommended frequency? So here we don't have a lot of data. What we know is that we can liberalize what we're doing. The trials for adjuvant bisphosphonates have ranged across a number of different time periods. I'll just share with you my personal practice, which is for those highest risk patients, I will offer this, not based on this endocrine sensitivity marker. That's based on whatever other clinical decision-making we would make around adjuvant bisphosphonates. And I just stick with the guidelines. I haven't been extending this for longer. Now, if you have a patient who, not for adjuvant therapy of breast cancer, but for management of osteopenia or osteoporosis, I would still consider using in that type of patient Q annual sort of bisphosphonate therapy just for bone density prevention, protection. I wouldn't make it a breast cancer decision. We just don't have data for that. Oh, last question here is how often do you check a DEXA? That's a great question. I don't think that's been really well studied. Changes in bone are long-lasting, long-term, and slow to happen. I check one at baseline. Depending on what that is, I may check it in a couple of years. If it shows a lot of bone loss and I'm trying to make an impact there, I might check it sooner than that. And then after a while, I'll just kind of hand it back to the primary care physician. So in his first few years, maybe a few times is what I would do. And for patients who are not at optimal bone density, of course, I would intervene. Last one is a 48-year-old female, hormone positive on TAM AI for 10 years. Can BCI be used for extending AI beyond 10 years? That's a fascinating question. I don't know that it can at this time. That data is even thinner. It really comes from a single study, MA17R, and that's TAM followed by AI followed by AI. So 15 total years of endocrine therapy. And to my knowledge, we don't have any data for how BCI speaks to endocrine sensitivity in cancers that are beyond that first 10 years now. So I think it's just a data-free zone. All right. Well, I thank everybody for their attention. If there are any other questions later on down the road, I'm not that hard to find. If you just type my name in on Google, and apparently people can find me. So please feel free to reach out at any point. Thank you so much.